Okay, good afternoon. We're going to go ahead and get started. Welcome, everyone. We only have one bill on the agenda today, but it looks like we've got almost everyone here. I know we've got one member at least who is racing to get here, but we will go ahead and call the roll.
Representative Bentley. Yes, sir. Representative Bratcher. Yes. Representative Bray. Representative Burke.
Here.
Representative Callaway.
Present.
Representative Camuel.
Here.
Representative Duval.
Here.
Representative Fraser Gordon. Representative Justice. Representative Neighbors.
Here.
Representative Rayburn.
Here.
Representative Raymer.
Here.
Representative Riley. Representative Rorks.
Here.
Representative Sharp. Representative Wilner.
Here.
Representative Whidden.
Here.
Vice Chair Dotson.
Present.
Chair Mosier.
I am here. Okay, we have a quorum established to do business, and we do have a committee sub. I'll entertain a motion on the committee sub. We have a motion and a second. All in favor, please say aye. Any opposed? Okay. Please proceed. Introduce yourselves for the record and proceed.
Madam Chair, Senator Philip Wheeler, 31st Senate District, Pikeville, Kentucky.
And I'm Mark Birdwhistle. I'm Chief Administrative Officer, UK Healthcare.
I'm Donovan Blackburn, President and CEO for Pikeville Medical Center.
Holly Harris, President and CEO of Appalachian Regional Healthcare.
Thank you.
Madam Chair and members of the committee, thank you for having this Monday afternoon committee meeting to hear Senate Bill 280, which I think can really be one of the most important pieces of legislation for rural health care in the Commonwealth of Kentucky in some time. Senate Bill 280 is a product of intensive negotiations which have taken place over the last 3 weeks between many of Kentucky's rural providers, led by Pikeville Medical Center and ARH, and the University of Kentucky, represented by Mr. Birdwhistle. It is a product of collaboration in order to make the hospitals of rural Kentucky, which are highly dependent upon the Medicaid program, more competitive and place them on an equal playing field with the more urban hospitals. It does that by creating what I think my friend Mr. Birdwhistle called a third way on Medicaid reimbursement. Currently, there are two primary programs for Medicaid reimbursement in Kentucky. The first is ATRIP, which some of you all may be familiar with. It is an equalization program for rural hospitals that was developed to fill in some of the gap that many of them who are heavily Medicaid dependent are suffering with compared to urban centers, which are more private pay. In the enhanced ATRIP program, which is received by the University of Kentucky and University of Louisville, which is a higher reimbursement rate that is meant to help them fund their residency and training program so that we can train future doctors for the Commonwealth. The third way that was developed in collaboration between Mr. Blackburn and Mr. Birdwhistle will create a new program that is essentially an equivalent reimbursement to the enhanced ATRIP for rural hospitals at level 2, 3, and 4 trauma centers that have a 35% or higher Medicaid payor mix. And what that will do is allow these folks to compete on a more level playing field with their urban counterparts and make up some of the lost grounds that rural health care has been experiencing in comparison to hospitals in the urban areas. The program as designed would also not impact the general fund. It does so through an intergovernmental transfer that will have to be developed by the local community. Many, such as the city of Pikeville, where I am from, do that through a local provider tax to come up with a match. That match is then reimbursed back to the hospital through the reimbursement rate, so it's essentially an accounting maneuver, more or less, but it allows the local provider to come up with the federal match in order to receive this enhanced rate. We would estimate that as many as 40 hospitals would be able to qualify for this enhanced rate, with many more able to qualify in the future. as they reach the quality metrics and other things associated with the underlying criteria. We feel that this bill is a win-win for rural health care in Kentucky, and I want to thank my partners here for getting together over the last 2 weeks and coming up with what I think is excellent legislation for rural health care and for the Commonwealth of Kentucky. I'll turn it over to Mr. Birdwhistle. He's been one of the primary architects to see whether anything. I guess I should also say this is really also dependent, of course, of whether the program is approved by CMS in Washington, D.C., so it is somewhat contingent, but we do have a very good indicators that it would likely qualify and be approved. So, Mr. Birdwhistle, I'll turn it over to you.
Thanks, Senator. I do feel like this is a
Will you make
win-
sure that your microphone is on and a little closer, maybe?
Let's try that number.
That's great. Thank you.
So I do feel like this program is a win-win situation. It goes a long way to addressing the problems that we encountered early in the session. The university program is approved for a number of years. The HRIP program has already been approved. Where we were struggling, we didn't want to do something that would trigger a review or a reopening of either of those two plans. So this solution will live on top of the HRIP program. So one of the requirements of this program will be everything in HRIP stays intact. This opportunity will allow for hospitals that are located in communities that have over 35% approximately of Medicaid population in that region to tap into the new program if they meet other things. One of the other features that I think is very attractive is they must be a level 2, 3, or 4 in a trauma certification. So that's going to increase the standard of care in Eastern Kentucky, encouraging all of these hospitals to build up their capacity to be ready for trauma. And I think that's an important piece to this. They would accept clinical rotations, which will help in the workforce development. They would meet the quality measures that the two universities are already meeting. UK and U of L have experienced significant changes in the quality and outcome. We stand ready to help other hospital systems meet those objectives. The last significant piece I would say is it would allow for physician and other professional reimbursement. The HRIP program is limited to hospital, inpatient, and outpatient services. The universities our plans have physicians, dentists, other health providers are able to get the average commercial rate, which will increase access to those as well. So I could go on forever because I love Medicaid and can talk about it forever, but I'll turn it over to Donovan and let him add on.
Again, thank you for the opportunity today. I think pretty much the senator and Mr. Birdwhistle has kind of summed up what the intent was and the concern is. Being in rural Eastern Kentucky, specifically with my counterpart here, Holly, it was extremely important for us to be able to not only make investments in the community of healthcare, meaning our relationship with the University of Pikeville, for example, on top of the relationship we have with UK, allows us to do more, realizing we're facing a national crisis in workforce with providers as well. So having that relationship with the university and be able to offer services and actually having the income coming through the federal government to be able to do so will certainly help stabilize not only the hospital, but also us as one of the leading employers in Eastern Kentucky as well. So I don't think there's much more I can add to what's already been said.
Thank you again for listening to us today. And from ARH's standpoint, we have 12 hospitals across Eastern Kentucky and serve very rural communities. And the existing HRIP program is vital to our hospitals and has kept many of them open over the past year. So thank you for your support of the existing HRIP program. And we're very excited about the prospect of the additional HRIP funding that would come from this third model. And you know, Donovan and I face the same challenges in Eastern Kentucky, and our counterparts that are in other rural communities across the Commonwealth also face these challenges. So this piece of legislation not only helps Eastern Kentucky, it helps all of our rural hospitals here in Kentucky. So thank you for having us today.
Okay, thank you. We do have a motion and a second on the bill, and we've got a couple of questions. I'll ask the first one and just make a comment. I appreciate this piece of legislation very much. I especially appreciate the work on the GME slots, the graduate medical education slots. This is typically a federal program. For those who don't know a lot about this, there are some state programs, universities who have a state GME, a certain number of slots. And so it looks like this is increasing those GME slots, which I worked on through the summer. Thank you, Mr. Birdwhistle. Do you have any idea how many slots this will open up for Kentucky?
I don't have a precise number. So the precise wording here is to accept clinical rotations. So we stop short of saying
I see.
you have to have a residency program. You know, we're working on that with a separate initiative.
That's right.
But these, they do interlock very well. So that's why we put the clinical rotations, that as we work to create the residency slots, they'll work hand in glove.
Well, right. Yeah, because you can't increase the GME slots without the facilities and the rotations. So,
Right.
Absolutely. Okay. Thank you. And then the committee sub adopted some language around pediatric teaching hospitals. Can you just explain that briefly?
So I think the language was a clarification. I think the committee that was the version passed in the Senate said pediatric hospitals. I think that raised some questions. So the new language says, as they serve patients 18 years and younger. So just to get some clarity. So in my mind, that was a technical revision.
Okay, good. All right. Well, thank you. Representative Callaway?
Thank you. Thank you all for taking the time. And I did address this with you, Senator, a moment ago, but just to put my constituents' minds at ease, we do have a fabulous new hospital from U of L in Bullitt County. So if you don't mind, just address the concern that I presented to you and how the amendment will fix that. Thank you.
Absolutely. There were some questions, I guess, based on some prior acquisitions by the University of Kentucky that, and I want to give Mr. Birdwhistle credit, he has said that he is actually for transparency. And so we put some language that as we move forward in the future, if they do, the universities, either the University of Kentucky or the University of Louisville, acquire new hospital systems or open new hospitals, really just acquisitions, that they would have to get consent of the General Assembly, which could either be through the budgetary process or a specific bill. Your hospital in Bullitt County, which my dear friend Mike Nemus had great concern about as well, will not be impacted whatsoever, as it will come online before the effective date of this bill. And again, I think it's part of the U of L hospital system itself, not an acquisition. So it will be that we made sure that Mike and you were taken care of in the committee substitute.
Thank you very much. Thank you, Chair.
Representative Bentley?
Thank you, Chair Lady. Is the level of payment to King's Daughter what we're trying to achieve with this bill? The UK is with them now?
So King's Daughters Health System currently receives their own average commercial rate. For a few months at the start of the deal when UK purchased King's Daughters, and they got the UK rate, which was high, admittedly, because of who we care for and all of our extra costs. For some time, King's Daughters has been paid through this program at their own average commercial rate. And what that means is the average of their Anthem rate, Humana rate, whatever the average of their hospitals' reimbursement from their commercial providers, not the UK's. Does that make sense? And then under this program, Pikeville will get exactly the same treatment. They would be paid their own average commercial rate. So this basically it does level the playing field between the two systems.
Yes, sir.
Just for the sake of my constituents, can you describe a trauma 2 level hospital?
I will defer to Donovan because he's the only level 2 trauma system in the state.
As compared, level 2, obviously, level 1 is the highest rating in the state, and that's a U of K and U of L. Pikeville Medical is the only level 2. We offer pretty much the same services that a UK or U of L offers with on-call staff. The major difference is that we're not a teaching hospital to make it, I guess, easy to understand. So we offer pretty much the same type of services that a UK or U of L would have.
Thank you, Chair Lady.
You're welcome. Representative Justice.
Thank you, Chair Lady. I have a couple questions and I'd like to speak on the bill. Would you say that this bill would ensure the survival or strengthen the rural hospitals in eastern Kentucky?
100%.
Absolutely.
I think that's a little bit rhetorical, but I wanted to say it.
Absolutely.
Would you say this would increase positive patient outcomes, create jobs, and aid in the recruitment of healthcare workforce, which is already at a historic low?
Given the emphasis on quality metrics and additional funding, I think that's very likely as well.
My district, the 94th, which is ARH, and a lot of my constituency go to Pikeville Medical Center. They kind of feel largely forgotten sometimes, very sparsely populated. I believe the statistic is approximately 77 or more percent Medicaid, Medicare patients. So like our business model back home is a little different than some of these more urban areas, and survival is a lot harder for us. We have quality providers. I think we just want to be treated fairly and get a better deal. The university situation with this bill, like Pikeville Medical Center, they have the optometry school, the DO school, nursing, dental schools coming. So they definitely service this area in a great way, and I think they earned the ability to get this bill. Do you see the potential without this bill? Do you see the potential for, or maybe this is already occurring, that entities such as UK or U of L will expand or somewhat encroach in these areas where there's already standing hospitals that could provide quality care?
Well, Representative Justice, I thank you for those comments and that question, and I believe that the product that you see before it is kind of a mechanism to transform or to promote a much more collaborative relationship between the university hospitals, and actually to hopefully expand on some of the great assets that you mentioned at the University of Pikeville, the dental school, the DO school, and things that this will allow Pikeville to potentially partner with, of course, our state universities as well as UPike through this model.
Let me add, and I gave a quick answer a moment ago because I didn't really want to get too much in depth, but this is really kind of the crux of the issue and why this came forward. And we look at specifically Pikeville Medical, and ARH has some of the same issues, is looking at the differential in the payment and being in a rural community with very high Medicaid, Medicare. But yet, because we are specifically Pikeville Medical Center, a regional transfer facility, then we incur a lot of the same costs. And when I talk about the level 1, level 2, without going too deep in what my answer was, Representative, because of that differential and being high Medicaid, Medicare, and also we have a lot of charitable patients that we both deal with pretty frequently, then obviously our finances, to say bluntly, isn't as strong as what you will find with somebody that has a high commercial rate, or in this case, with the university rate. And that's kind of how this debate first started. So when we're looking at the University of Pikeville, for example, there are 3 medical schools in the state of Kentucky: U of L, UK, and University of Pikeville. But those students still need an area for clinical rotations, and there's a cost associated with that. But we don't receive an additional reimbursement, and therefore there isn't truly a level playing field when we're trying to address the national crisis that we're faced with a shortfall in not just healthcare workers such as RNs, but also physicians. Right now, they're projecting by 2035 124,000 shortfall in physicians alone. So having not only higher ed available, but also having healthcare facilities like ARH and Pikeville Medical Center treated fairly, in being with this new rate will certainly put us not only on a equal playing field, but also you look at us from who we are as organizations. Rural Eastern Kentucky specifically, and other parts of the rural state, we're also the leading employer within the community. So having stability in these areas is not only for the name of healthcare and for recruitment and for other reasons also is important, but also having the opportunity to prop up higher ed, the banking community, the finance community in general is extremely important to our part of the state as well. So I appreciate those questions.
And I really support, I'm glad this is a collaborative thing, and I really support the universities. I wasn't trying to start a war. I'm actually alumni of University of Louisville with a dental degree. And I think the key word is just treated fairly. We don't want something extra. You still have to meet the qualifications. This doesn't affect the state's budget. And, a lot of times people from the mountains want to stay in the mountains, but they also want a certain level of income and job security. And I think this would allow more potential for people to stay home and provide health care to this area.
So I appreciate your questions and the spirit behind them. There's an extra benefit that I think we need to be aware of is with the rural hospitals having additional revenue, we hope that this will allow them to be able to keep the patients closer to home for longer. Many of you have called me trying to get patients into UK hospital. We're packed. So this is a side benefit of this is that if with the revenues, and Holly's nodding her head because she knows that's where I'm headed, is this will enable other hospital systems and in the rural areas to be able to keep the patients closer to home and not have to send them to UK. We want the ones that need to come to UK for advance of specialty care to come. We want people do better. They have better health outcomes if they can get that care closer to home. And this, a secondary objective of this, will enhance that ability through the finance.
One more comment, Chair Lady.
One more.
I think the possibilities for this is endless. I mean, we talked earlier in the year about the lack of health care, mental health care facilities in our area. And the mental health care issues are increasing. So I think we could expand in that way. And I'm just glad that you guys are doing this. It really means a lot to us back home. And I think it would ensure the continuation of quality health care in the 94th District. Thank you.
Okay, thank you. This is a great discussion. This is a really creative, collaborative piece of legislation. Thank you for bringing this. I really love the more we talk about this, the more we really realize the benefits will improve not only the standard of care in our rural areas, but increase our and improve our healthcare workforce situation. Certainly, the collaboration and strengthening those partnerships is key to doing that. And I'm glad that Representative Justice clarified that really there is no burden on the state to provide these funds. This is the state match is being provided by the participants. And I appreciate that. I think we all appreciate that in a budget year especially. So
Absolutely, Madam Chair. And if I might take a minute of privilege, I'd like to thank Chris Joffrey. He's been a real a key participant in these negotiations and drafting. I know he's put in some long hours to make this final product a reality, and without great staff like that, obviously, we wouldn't be able to do our job. So thank you, Chris.
Thank you. Thank you for pointing that out. We do have amazing staff here, some of the brightest folks I've ever worked with. So I appreciate that, and thank you, Chris. Thank you, everyone, actually. So I don't see any further questions or any concerns. So DJ, please take the roll.
Representative Bentley. Representative Bratcher.
Yes.
Representative Bray. Representative Burke.
Yes.
Representative Callaway.
Aye.
Representative Camuel.
Yes.
Representative Dotson.
May I explain my yes vote? Just want to say 51 years ago, I was born in Pikeville Methodist Hospital, now Pikeville Medical Center. Thank you.
Representative Duval.
Absolutely yes.
Representative Frazier Gordon. Representative Justice.
I'd like to explain my yes vote as well. Like you pointed out, the patients that are having to travel to UK, it burdens those universities, and also being one of the poorest areas to drive that far sometimes is not even feasible. So I too was born at Pikeville Medical Center, and I'm glad about this. It's a win-win for everyone, so it's a yes. Thank you.
Representative Neighbors.
Yes.
Representative Rayburn.
Yes.
Representative Raymer.
Yes.
Representative Riley. Representative Rourke.
Yes.
Representative Sharp. Representative Wilner.
Yes.
Representative Whidden.
Yes.
Chair Mosier.
Yes. Okay. Senate Bill, 280, as amended by the committee substitute, passes with favorable expression, actually unanimously. Unfortunately, we don't have consent here, or I would make that motion. Congratulations. Thank you very much for your work. Okay, having no further business to come before this committee, we are adjourned.